Hello everyone, welcome back to another video on the channel. I'm so happy to be here with you guys. We're going to be going over the endocrinology episode 2. We're going to take again more complicated and highly tested topics on the endocrinology and internal medicine board exam and break it down, simplify them, make sure you don't miss any parts of those educational objectives that board of internal medicine loves to test. Okay, as you have seen, I'm trying to tweak the videos around, make them a little better, improve my instructions, make the questions more relevant for you guys on each episode. If you guys are liking it, please drop a comment, like, subscribe, let me know how you feel. If you guys don't make me any feedback, I will not know what to improve and change. I really do appreciate comments, even if it's bad. If you want to tell me something about the video that you want me to improve or something that you don't like, I'd like to hear it. So please go ahead and do that. The notes are available on Patreon. You can watch the video and have all the notes, but really those are there if you wanted to donate to my purpose, since I'm making all these videos and using my own time. If you wanted to go ahead and donate to me for those notes, that would be amazing. Otherwise, no pressure there, you don't have to. I'm gonna go ahead and get started. Okay, so this is the first question. This is a 32-year-old woman that presents with fatigue, heat intolerance, weight loss, palpitations, and tremors. Now again, on boards you may not get all of those. Physical exam reveals a diffusely enlarged thyroid and exophthalmos. Lab studies show suppressed TSH, elevated free T4, mildly elevated serum calcium. Urinalysis reveals elevated calcium excretion, and bone densitometry reveals reduced bone mineral density. So which of the following best explains the mechanism of this patient's hypercalcemia? So go ahead and pause the video right here and pick your answer. We're going to go through each of the options together. All right, so let me get that up out of the way. So this, as you can see, the patient has basically signs of hyperthyroidism, thyrotoxicosis specifically, secondary to probably Graves' disease, right? And all the boards love to know if you understand how that's also linked to hypercalcemia. Basically, they want you to know, how does hyperthyroidism also cause hypercalcemia? Okay, and they can test that in many ways. So let's see. So of course it's through osteoclastic bone resorption. Okay, so thyrotoxicosis leads to increased osteoclast activity, increasing bone resorption, and release of calcium from the bone to the serum. So despite elevated calcium, PTH is suppressed, causing renal calcium wasting and hypercalciuria. Okay, so they want you to know that the kind of hypercalcemia you get in this kind of presentation is going to be a PTH suppressed kind, and there's going to be a lot of calcium excreting into the urine. Okay, so the key clue, symptoms of thyrotoxicosis, of course everybody knows that. Just recognize that these can also happen. Hypercalcemia, hypercalciuria, and low bone density are also associated. So you need to kind of realize the association there. So PTH secretion would be wrong. PTH is suppressed in thyrotoxicosis, associated hypercalcemia. PTH-RP production, this would be in malignancies, lung especially. And cancers can do that. Increased osteoclastic bone resorption, this would be the correct effect. And then the increased GI calcium absorption, that's not relevant really. PTH suppression and low 125 vitamin D reduce GI absorption. So vitamin D intoxication would increase GI absorption and calcium reabsorption, not common in this presentation, right? And again, very rare. So hypercalcemia workup, they want you to know. So whenever anyone has high calcium in the hospital, you want to measure the PTH. If the PTH is low, think about non-PTH mediated causes, right? So check the thyroid function. Very important always to get the thyroid function to see if there is any thyrotoxicosis in the background or in hyperthyroidism in the background. Confirm the bone resorption. And how you do that, you look at the bone density, you can check for the urine calcium, right? And you can do that, the urinary 24-hour urine calcium check, and you go from there. Now, hyperthyroid plus hypercalcemia plus bone loss, that's called also thyrotoxic bone disease. Very important. Not many people are aware of this. The keywords where this patient had all of those. Low bone, in addition, he also has low bone density and hypercalciuria. Okay, so guidelines and evidence-based practice, right? So that's what I always ask the AI to check for us to make sure everything is up to date with the American guidelines. These societies are American societies. Thyrotoxic is a well-known cause of PTH-independent hypercalcemia. Just remember that. Treatment of the hyperthyroidism often normalizes calcium levels. Bone density may not fully recover, especially if prolonged thyrotoxicosis has been basically ongoing for a long time and the patient is not really being treated over time. The takeaway is just remember this is PTH independent process, and it happens through increased osteoclastic bone resorption and bone loss, and these patients are actually at high risk of fractures, correct? And always remember to evaluate also the thyroid function whenever you have a hypercalcemic patient. Of course, the algorithms that you see on regular question banks is always says, okay, hypercalcemia, check a PTH, but don't forget that is not the only thing. You also need to check the TSH if there's high index of suspicion that maybe there's a thyroid issue in the background going on. Okay, so very, very high yield question. I hope you guys enjoyed this one. If you're liking these questions and the explanations are are making sense to you, please drop a like, comment, subscribe. Let me know what you think. Okay, so let's move on to the next question. All right, so this is a 40-year-old woman. She presents with fatigue, heat intolerance, and weight loss. She denies neck pain. She has no history of autoimmune disease. On physical exam, there's no palpable thyroid enlargement or eye changes. Labs reveal suppressed TSH and elevated free T3. Radioactive iodine uptake is actually less than 1%. Then they also check a serum thyroglobulin that is undetectable. Okay, so which of the following is the most likely cause of this patient's symptoms? Go ahead and pause the video right here, pick your answer, and then we're going to go through them together. All right, so always the questions like this about thyroid function, and they're going to be testing you to know to go down the basically the algorithm path to see if you know if one hormone is low, and then what do you test next, what do you test next, and what do you test next. Okay, so this is factitious thyrotoxicosis, but let's go through why this is factitious. So factitious thyrotoxicosis, when a person intentionally or unintentionally ingests thyroid hormone, right, it causes low TSH, but also they don't want you to hold there. They want you to know that this is associated with low thyroglobulin and low radioactive iodine uptake. So you need to know, and this is all due to feedback suppression, right? But you need to know if this is the thyroglobulin is low or high, especially when you know the radioactive iodine uptake is actually low. So I'll show you how. So this patient has thyrotoxicosis symptoms. There's no goiter, right? There's no neck pain. So you're not thinking about, a thyroiditis. No eye signs, okay? Low radioactive iodine uptake and low thyroglobulin. So in subacute thyroiditis, for example, you would have painful neck and thyroid gland, and you have thyroglobulin that is endogenously produced elevated, because the body will produce that thyroglobulin to support the elevated T4, right? So in this case, that we have a low thyroglobulin because the patient is taking the thyroid hormone on their own. The body is not producing the thyroglobulin. So the classic picture of this is always a low uptake and a low thyroglobulin. Graves' disease would be, would have increased iodine uptake and then eye findings, maybe goiter. Iodine-induced hyperthyroidism can suppress uptake, but thyroglobulin is never low on that case as well. And stroma overi, right? Remember, this is a rare tumor, but again, because it's endogenous, there's still thyroglobulin there. So you may have a normal or even elevated thyroglobulin with the endogenous, basically, source that is not from the thyroid gland, right? So the stepwise approach to low radioactive iodine uptake in thyrotoxicosis, with the next step right after that is check the thyroglobulin, because you need to know if this is an exogenous hormone that's been isolated exogenous intake of synthroid or whatever generic name it is, or is there a secondary source of thyroid hormone produced by the body with elevated thyroglobulin that to carry that. Okay, so look for the clinical signs always, right? So pain, maybe subacute goiter, eye signs, and then think about these things, and don't forget about this rare ovarian tumor. They try to make you distinguish between factitious and stroma ovari. Okay, this is where internal medicine gets very tricky questions, but once you simplify, you really understand where the thyroglobulin is produced from sources inside the body, then this becomes way understandable and simplified. Okay, so pattern recognition. Okay, TSH is low, T3, T4 is high, you have a low radioactive iodine uptake, and if the thyroglobulin is low, think about the patient maybe taking this synthroid for maybe weight loss, maybe they have a psychiatric condition, and maybe someone who's not even have that prescription, but they're taking their family member's prescription. I've had that so many times in the hospital where patient was taking someone's laxatives to lose weight, or they were taking someone's thyroid hormone to lose weight. This happens every day, guys, so we need to really know this is not too complicated. It's just because there's so many other topics and mixes into the hormones, the feedback loops, and it makes it really difficult. But once you understand this is it, guys. Now when we finish this video today, I'm going to show you what I think really brilliance means. Okay, so as per the ATA, the American Thyroid Association and Endocrine Society, serum thyroglobulin is essential in differentiating exogenous versus endogenous thyrotoxicosis. Factitious has suppressed thyroglobulin and low uptake. Just remember that. And distinguish it from other etiologies. The takeaway is that factitious thyrotoxicosis should be suspected in patients with low and suppressed thyroglobulin. Again, keep repeating, I keep saying these, and they just to make sure you do not forget this, especially in those without goiter or eye findings. Always consider exogenous hormone ingestion in an unexplained hyperthyroidism. Okay, guys. If you're liking the video, don't forget, please, I really need your feedback. Okay, just like these hormone feedbacks, I need you guys feedback on the video, so I know we're just starting off, the channel is new. I need to I'm working on it. I'm spending a lot of time on this channel to make it the best most helpful resource as I can. There's so many channels on YouTube nowadays that they do not really add anything to you. They are just there as clickbait, or to try to pull you in for, and then you're just wasting your time scrolling and scrolling and scrolling. This is not that. This is highly educational. We're trying to break down board questions. We're trying to make this process easy for all of us. For me, even if 5 years from now, I'm 10 years from now, I'm doing my research, I'll be watching my own videos. Honestly, these are great in terms of being able to watch them back and back. It's like a playlist that you can play and tackle the highest questions. So let's go to the third question. Okay, guys, this is a 47-year-old woman. She's referred to endocrinology after incidental finding of hypercalcemia on her routine labs. She's asymptomatic. Her calcium is 11.4 and PTH is elevated. Bone density shows normal T-score. Creatinine is normal. A 24-hour urine calcium excretion is 420. Which of the following is the most appropriate next step? So again, in that question, previous one, they could have asked you what is the most appropriate next step, and you would have to check a thyroglobulin there. In this question, they could have what would be the next appropriate test, and that would have been a 24-hour urine calcium excretion. So these questions have all of the educational objectives, but they can tweak it and ask things within this question as a question on its own. Just remember that, okay? But here they're taking everything for the workup and they're asking what would you do next. So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So have you picked a referral for pancreatectomy? But this always gets tested. to know the indications for parathyroidectomy. Okay, they want you to absolutely know who needs to get parathyroidectomy. I can't say it like anywhere else. This is always tested. Okay, so primary hyperparathyroidism causes autonomous PTH secretion, right, leading to hypercalcemia, increased bone resorption, renal calcium loss, possible kidney stones, or osteoporosis. Okay, and they may not give you the symptoms, and they may not give you the hypercalcemia level. They may tell you symptoms, and one of them, they may tell you this patient is developing possible kidney stones. You're having bone loss. They may tell you that stuff. But even asymptomatic patients have high risk for complications. So the question dissection answer is that the things that you need to know about indication: age less than 50, elevated calcium, elevated PTH, and a urine calcium greater than 400 milligrams a day. And these numbers that I give on my episodes, you absolutely need to know. This is someone, if you're gonna ace your board exam and you want to do great and take all the points that most people get wrong, try to remember the numbers. Okay, so the less than limit. So first was observation. That's incorrect, because first of all, age is less than 50, and you need to know that that is a clear surgical indication for parathyroidectomy on its own. So observation is not correct. Bisphosphonate is used for osteoporosis, but again, it's not first line in PHPT without the bone disease, right? Parathyroidectomy meets surgical criteria, right? If it is the guy, it needs to meet with his age less than 50 plus especially elevated urinary calcium in a day. And serum calcite reserved for non-surgical candidates or secondary hyperparathyroidism. Checking vitamin D is not urgent. Diagnosis is already confirmed and surgical criteria are met. So let's go through the indications for surgery, right? So age less than 50, symptomatic hypercalcemia. So if they have all the symptoms: bone stones, grown psychiatric overtones, complications, osteoporosis, CKD, kidney stones, elevated risks of complications happen with serum calciums that are greater than greater than equal to 1 above normal. 24-hour urine calcium greater than 400 milligrams a day. Okay, very important. This patient qualifies on age and urinary calcium. So you can see here, hypercalcemia, elevated PTH, young patient, think surgery. And when you have this 24-hour urine, and I'll tell you why, this is important. This is the red flag that you need to put up. And this is the American Association of Endocrine Surgeons, AAES, and the ATA. They do recommend the parathyroidectomy when these are met. Okay. And the takeaway is going to repeat the same thing that we said. And the reason we check the urine calcium is sometimes the patient could have FHH, and this is not in here, it didn't really tell you, but if they have hypocalciuria, that could be that familial condition, and the treatment for that is not parathyroidectomy. So that's why you need to know that they need to be showing these signs before you actually go with surgery. Okay, guys, if you enjoyed this episode, thank you so much for being here. Thank you for watching all the way to the end. Don't forget, like and subscribe, put the notifications up. We're gonna have daily episodes of high yield questions broken down, made simple. And I was gonna show you guys this little thing that I created, simplicity. Okay, I wanted to say simplicity is brilliance. Okay, it's literally the brilliance. The more complicated things are, that means something is not working. If someone is not able to break down difficult topics, that is not good. That is not brilliance. And by the way, side point, this picture of me at home, I used the new ChatGPT image generated, and I just turned myself into an anime. I thought it was pretty cool. I'm trying to keep up with all the changes and the things we find on with AI. So I hope you guys enjoyed the episode. Don't forget to like and subscribe. I'll see you on the next one. Okay.